Okay, we're going to take a bit of a deeper dive into Matilda's agony and Mimisa's pain and bleeding. Um, and we're not only going to discuss endometriosis and adenomyosis, we are going to discuss two other common causes of chronic pelvic pain. Um, this topic of endometriosis and adenomyosis is covered by Dr. Richardson as well, so I'm not going into too much detail. And you do also have to look at Dr. Kennedy's PowerPoint on chronic pelvic pain because he's got a much broader view. But I thought I would just get extremely practical about things that I see all the time in OPD as causes of chronic pelvic pain. So let's get started. So we're going to be discussing endometriosis, adenomyosis, chronic PID, and irritable bowel syndrome, because even if women have got clearly bowel-related symptoms, often just because you're a woman, you get sent to a gynae clinic. So we do need to talk a little bit about that because it's a very common differential, and I actually end up making that diagnosis quite often. All right, remember there's a picture at the top there of adhesions. Remember that adhesions are often involved with endometriosis and chronic PID. And that picture is very nicely illustrative of what can happen in the pelvis when you have adhesions. Okay, so let's look at the symptoms of endometriosis and adenomyosis. So both of them will have lower abdominal pain, and there will be a very clear pattern of it being much worse during or just before their period. But when adhesions form, that pain can also happen in between periods. But there's always going to be a very definite flavor of severe worsening around the time of menstruation. Simple analgesia like Panado doesn't begin to touch sides. So if students can well, they can be students, but patients, if patients can afford to, they will often buy things like Myprodol or Still Pain from the pharmacy, and they will end up taking handfuls sometimes because the pain is so severe, and that might have its own effect. So you do need to ask about abuse of over-the-counter medications. Women with endometriosis and adenomyosis will both probably experience dyspareunia if they are sexually active. And both of them, as we saw with Matilda and Mimisa, will have a significant impact on their quality of life, their ability to work, study, parent, be a partner, just about any aspect. They may also struggle with fertility, especially women with endometriosis, because of the fact that all of those adhesions distort the pelvic cavity and the tubal anatomy as well. Adenomyosis, in addition to all of this, will have very heavy periods because they've got that hugely increased surface area of endometrial glands within the myometrium. And it usually begins sometime after pregnancy. Now, keep in mind that one of the interventions that we use is contraception. So sometimes a woman might have been on contraception for a long time and then suddenly come off of contraception for whatever reason, and now suddenly start getting symptoms. That doesn't mean that she hasn't had endometriosis all along. It just means that it's been unwittingly managed by the contraception. Now, when it comes to chronic PID, patients can have low abdominal pain, of course, that's why they come. They also may have dyspareunia, they may have noticed a discharge, or they may not. As we've spoken about before, this is often a silent infection. They may struggle with fertility, again, because of the adhesions, because of occlusion of the tubes. In fact, that's one of the commonest causes of fertility. And also, they seldom have response to simple analgesia. So again, asking about over-the-counter drugs. And their symptoms may or may not impact significantly on their quality of life. When it comes to irritable bowel syndrome, this is a cause of chronic pelvic pain or chronic low abdominal pain in young people. You're never going to make that diagnosis in an older woman. So they will complain of low abdominal pain, and it will be associated with bowel symptoms. So either diarrhea or looser stools, alternating with constipation or just constipation. And one of the most significant differentiating questions you can ask is about relief after defecation. So if the pain is markedly improved after defecation, that's much more likely to be a bowel-related issue. it can have a significant impact on quality of life, or it can just be an annoyance. And it doesn't respond to normal analgesia because it's a spasmodic pain, and spasm doesn't respond to Panado. Okay. Now we're moving on to some of the key features. There may be other features as well, but these are the main ones that would help you think about these various diagnoses. So on examination, women with endometriosis and adenomyosis will probably have lower abdominal pain when you examine them, so right or left iliac fossa pain. They may not if they are not about to have their period or they're not having their period. Sometimes the pain is confined only to during the menstrual cycle, but as I said before, if there are adhesions, it can then become more far-reaching pain. So they may or may not have pain. If they don't have pain when you examine them, it doesn't mean that they don't have endometriosis or adenomyosis. Okay, you've got to go very heavily on the history as well. For both endo and adenomyosis, they'll usually have a normal vulva and vagina, and both of their gynae examinations can be non-tender, but usually it will be tender when you put the speculum in, and it will be tender when you do the bimanual examination. Women with endometriosis will have a normal sized uterus, but the uterus may be immobile, so it may be fixed because of all the adhesions. And if you'll remember the picture, that women get deposits all over the pelvis, so you might be able to feel nodules in some of the ligaments. And in this case, you would want to do a rectal examination also to check for nodules in the rectovaginal septum. With adenomyosis, also, they're likely to be tender with the vaginal examination. You're unlikely to feel nodules because remember here the endometrial tissue is within the walls of the myometrium. It's not in the pelvis. When it comes to chronic PID, when you examine a patient, they may well, in fact, they probably will have right or left iliac fossa pain or just generalized lower abdominal pain. On gynae examination, they may have a discharge visible at the introitus or visible on speculum. And it might also be very tender when you put a speculum in or when you insert your fingers to do a bimanual because of the chronic low-grade infection that's happening and because of the adhesions. You're not going to feel nodules in somebody who has PID. You may, usually if somebody has a tubo-ovarian complex, it will be a much more acute presentation. Now remember, we're talking about women who've had symptoms for 3 to 6 months or longer. But you can sometimes have a woman with an ovarian mass in chronic PID, although it's uncommon. Then with IBS, you may see some bloating, and the person might have discomfort throughout the abdomen. You may feel some, if it's a slender patient, you may feel some fecal loading in the descending colon. The gynae exam will be completely normal. And the rectal exam itself will be normal, but you might see hemorrhoids around the anus because of the link with constipation to IBS. So extreme straining causes hemorrhoids. Okay, moving on to investigation and management. In terms of investigations, for endometriosis and adenomyosis, so if you look at your side room investigations, you don't really need to do an HB for endometriosis because heavy bleeding is not an issue, but you do need to do an HB for adenomyosis because of the heavy bleeding. And then, of course, every gynae patient will end up having a scan. With endometriosis, it's very helpful if you do see an endometrioma, but not seeing an endometrioma doesn't exclude the diagnosis. The amount of pain is not always proportional to the size of or number of the deposit. So you could have a tiny little deposit hiding somewhere behind the bowel, causing a huge amount of pain. So a scan doesn't always pick it up. You may, however, also see distorted anatomy if you've got grade 4 endometriosis, which is severe with massive extensive adhesions. In adenomyosis, the scan is going to show you a globular uterus. Dr. Richardson showed you that in her talk. And you might see a disruption of the endomyometrial junction, and you might actually see invasion of the endometrium into the myometrial tissue. With chronic PID, Remember, adhesions, adhesions, adhesions. You're probably going to see one or both tubes as hydrosalpinges because of that chronic inflammation and scarring. And you might see organizing free fluid. So if there is a low-grade ongoing infection, there can be pus, for example, in the pouch of Douglas, and the body's role is to deal with that abnormal tissue. So it starts organizing it and fibrosing it, and that is what causes the adhesion. So you can see that on the scan if it's there. Whereas in IBS, there will be a completely normal scan. Okay, we're going to take a break now, and I'm going to come back to management in the next set of narrated slides.